Hello, everyone, and thank you for being a part of our 4th annual National Alzheimer's Buddies Virtual Symposium. My name is Jillian Lee, and I'm the CEO at National Alzheimer's Buddies. National Alzheimer's Buddies is a nonprofit that seeks to alleviate the social and emotional challenges that stem from Alzheimer's disease by building friendships between college volunteers and residents at memory care facilities. We believe that the volunteer-resident connection serves the purpose of engaging residents, reducing feelings of isolation and social disengagement that often arise from living with Alzheimer's disease and related dementias. We currently have established over 40 college chapters in the United States with over 600 student volunteers, and we are continuing to expand.
Hi everyone, my name is Leo Zhang and I'm currently serving as the Chief Diversity Officer at National Alzheimer's Buddies. Every year, National Alzheimer's Buddies hosts this virtual symposium in order to raise awareness and educate the community. The theme for this year's symposium is Advancing Dementia Care. This theme encapsulates the many recent breakthrough pharmaceutical treatments for Alzheimer's disease, and we wanted to also highlight the strides being taken to address disparities in Alzheimer's disease research, community education, and quality of care. Over the next several hours, our featured speakers and panelists will address the topic of dementia care from a wide range of perspectives. They will enlighten us on new scientific treatments being developed, emphasize the importance of equitable practices and legislative advocacy, discuss the most effective methods of reaching underserved communities, and share their personal journeys. As indicated on the event itinerary, the symposium will consist of 3 expert speakers, a physician-scientist panel discussing the most recent advances in Alzheimer's treatments, and a roundtable discussion of addressing disparities in dementia care. No matter what your background or experience with dementia is, we are so happy that you could join us today and hope that you will find something to take away. So we'll be starting today off with our first speaker, Dr. John Sims. Dr. John Sims is a board-certified specialist in neurology, vascular neurology, and neurocritical care who currently works as a senior medical director in the neuroscience business unit at Eli Lilly and Company, supporting multiple assets in the development phase. Dr. Sims is the head of medical development for donanemab and the global brand development leader for solanezumab, both of which are promising new pharmaceutical treatments for Alzheimer's disease. Prior to joining Eli Lilly, Dr. Sims was assistant professor of neurology at Harvard Medical School and director of neurocritical care at Massachusetts General Hospital. It is my pleasure to share with you Dr. John Sims.
Can you hear me?
Yes, yep.
Okay, first start here, and then can you see the slides?
Yes, we can. Thank you.
All right. Thank you very much for inviting me here. And thank you for everything you do to make this disease less impactful on patients and families. It's quite a devastating disease. Before COVID, it was the 6th leading cause of death in America for people over 65, and it had no way to stop it. And we're now entering into a new age where we're starting to finally break open this black box and have some solutions for people. So it's exciting to talk today. All right, just a couple of acknowledgments. Yeah, I do work for Eli Lilly, and I want to thank all the families. There's the term, it takes a village. It actually takes the world to solve this disease. We have to go worldwide to do these kinds of studies, and it takes a lot of people, thousands and thousands of people. I want to thank some of the people who've helped make slides here. And then also just remind you that what I'm talking about isn't approved yet, and even some of the diagnostic tests that I'm going to talk about are also still investigational, but are promising. I'm going to spend a little bit of time on this first slide, just to walk through for some people who are a little less familiar with the disease process. On the left is we call these the Jack curves. Clifford Jack developed them from Mayo Clinic. And on the far left, you'll see this kind of blue dotted line. I don't know if you can see my cursor or not. I wonder if I can get a highlighter here. Let's do a laser pointer. Okay, maybe you can see that. Okay, so there's this blue curve here, and that represents what we call CSF, or cerebral spinal fluid. That's doing a spinal tap. And we can see some early changes as this starts to become abnormal. It starts to drop in the fluid. And as it's dropping, we see that this protein here starts to depositing. This is the next dotted line. So it starts depositing into the brain. It's a very sticky protein and starts building up. And it's very much like cholesterol that builds up in your blood vessels. You know, starting at the age of 50, you start getting these deposits building up in your blood vessel. And similarly, you get these building up in your brain. As this builds up over time, then we start seeing some of these other things. So again, back in the cerebral spinal fluid, we see some of the earliest changes of what we call tau. It's another protein, and I'll talk about that as well. And like cardiovascular disease, where amyloid plaque is like cholesterol, the tau is a lot like the thrombosis or the clot that finally kind of injures the tissue being served by the blood vessel. And then once it starts building up, the brain really starts to lose tissue and get quite impaired. And then over time, we see that impairment in various ways, like on MRIs, as the brain loses tissue. And then it loses enough tissue that people can't compensate. You know, that writing the note for yourself no longer works very well. You start forgetting, you know, all your passwords and where you get your groceries and things like that, and how to cook. And then you eventually pass from this normal stage to what we call mild cognitive impairment. And in mild cognitive impairment, you're impaired, but you have enough function to kind of compensate. And then you go into the dementia phase where you really can't compensate anymore. And then we break the dementia phase into a mild dementia, a moderate dementia, and a severe dementia. As I mentioned, this protein, which is here now in the middle panel, we call it A beta. It is a protein that's cleaved from another important protein in the brain, and it's fairly common protein. And you and I are all making this protein constantly. But it's a sticky protein, and over time, and those people with higher risk factors, they start to build this protein up in the brain, and it sticks around in clumps outside the cell, and eventually causes impairment, again, leading to this tau accumulation. And what we did with the antibody, so donanemab is an antibody. The nice thing about antibodies is they're very specific, and so you can make them kind of like little smart bombs to go after very specific targets. And so it binds a form of A beta. These first two amino acids get cleaved off after it sits in the plaque over a period of time. And then there's a pyroglutamate change here, and this antibody recognizes that. So it only recognizes this plaque form. And that's part of the advantage of it, because it avoids all other species and it makes it all highly effective in removing a plaque. And so this is on the right side is the phase 2 study, and this was the very first study in disease modification to hit its primary outcome, to specify a primary outcome and show a treatment effect as pre-specified. And it had 32% slowing on this scale that we call the IDRIS. And as you can see below, it had very robust amyloid plaque removal with about 80. So we score the amyloid on a PET scan, a positron emission tomography scan, and we can measure that. And I'll show you an equivalent of some images. And it drops quite a bit. So 100 would be kind of the normal level of a patient with dementia. And so we're going from about 100 to about 80, and it continues to drop. And meanwhile, placebo people just tend to generally increase a little bit slowly over time. Okay, so let's see here. Go for it. Okay, so this is an example of a PET scan. Now, this is a PET scan of tau. So this is that other protein that builds up, and this is new in this space. In fact, we're the only ones to use this tracer and enroll everybody using and characterizing people by this tau. And over here are people who might be amyloid positive but have very little tau, and they have it kind of down here in the part of the brain we call the temporal lobe. This is right here by your ear. And it's really involved in memory, and it has other things like, sound processing, spatial processing, and it's a very important structure. But it's where tau starts, and then it starts spreading out from there. and going kind of to the back part of the brain, which is where some visual processing occurs. And then over time, it spreads forward to the parietal lobes, and then kind of the last parts of the lobes that get taken out are the frontal lobes, and that's kind of where you plan things. You have executive functions. You think about how you plan a meal, cook, things you're going to go, which row you're going to go to for shopping, right? You're going to first get your milk, and then you're first going to get your non-cold stuff first, and then you get your cold stuff last. That's kind of the executive planning aspect, and this is the part that gets kind of later in the brain. So we enrolled in that first phase 2 study. We enrolled people only here. Now, amyloid, as I showed you, is early in the disease and has lots of promise. In fact, it probably has most promise here in the earliest stages before tau starts building up. But these people are progressing much slower, and so they take a different trial design. They need a longer study period of time. So we took kind of a Goldilocks area. Here we were concerned that the people have gone so far into the disease that it's really hard to reverse it. So you can think of water putting out a campfire, but it won't be good enough to put out a house fire. And so people here are pretty far along the disease, and so they're a little harder to slow down. So the first trial, phase 2, did enroll this group, and then the phase 3, to reproduce the study, we wanted to enroll this group again, but we also didn't want to leave people behind, and so we enrolled this group even though we thought they might be harder to treat. So this is the study design for donanemab. So people were randomized 1-to-1, so they went into a placebo group or to donanemab. And donanemab we titrated, so they get a 700 milligram dose. This is delivered intravenously. They get 3 doses of that, and they get 1 dose every month. So this is given every month. And then they escalate to double that dose for the remainder of kind of a month and a half time period. Now, what's very unique about our trial compared to almost all the other trials in this space is that once we removed this plaque, we allowed people to stop taking the medicine. So, but we have to do it in a blinded fashion so people don't know what's happening, right? All this is blinded. And so in a blinded fashion at 24 weeks, if their amyloid PET scan here was negative, we'd removed all the amyloid, then we switched the drug to saline, and they were getting saline infusions for the rest of the time. That could also happen here at 1 year as well. And then we measured amyloid here again at the end of the study. We only had tau imaging at the beginning and the end. And we do MRIs quite frequently here to follow one of the main risk factors, which is ARIA, and I'll talk about some of the safety issues with these medications towards the end here. So what you see here is that we did, in fact, reproduce our study. In fact, this is the first replication now of a trial where the primary outcome was first specified and was positive, and then we have reproduced the data over here on the left. So this is the phase 2 data again. And you can see that it's quite a remarkable replication. Almost the same value of change is there. Obviously, we have a lot more people since this is a phase 3 study. And with the more people, we have more power to see treatment effects even as early as 12 weeks. And the treatment slowing is about the same, right? It's about 32 to 35% slowing of the disease. And this is, again, in that low to medium population, so that kind of earlier pathology phase. So now if we look at this in a different way, and we look at the people who have more disease, then you can see here, this is the whole population. Now this includes the people early in the disease and all the people with the later stages of disease. And you can see the gray line is the placebo here, and look how much more they decline over this 18 months. They decline a lot more in points compared to the earlier disease stage, which makes sense. But it's the first time we have really shown this in a trial. And then the treatment effect is still significant, but notice that the relative treatment effect gets less as you get later into disease, which is an important takeaway message, I think, for the whole field, and that is that we need to do better at making the diagnosis earlier. Sadly, our system diagnoses people late in the stage when they're in moderate stages of disease, and here we're enrolling a patient population that's MCI and mild AD, so earlier than when most people get their diagnosis. So we have, remember, we're taking people off of drug here as early as the 24 weeks, but yet, even though more and more people on the treatment are coming off drug, we still see increasing separation over time. This is also true for the CDR sum of boxes. This is another scale that's very commonly used across all of the trials. And here again, we see the exact same pattern that later stages of the disease, people go much faster and decline much faster. Still a significant treatment effect, but again, the relative slowing here is less than what you see for the later stages, for the earlier stages of the disease. What does the CDR sum of boxes measure? It's usually a scale that's recorded and scored by the physician. He or she has a conversation with the caregiver or a partner, and says, how did Johnny do with getting around town today? Did he have any problems? And goes through a long list of questions, and they try to look at memory. Orientation is kind of like, do they remember what month it is, what year it is, those kinds of things, like who's the president of the United States, judgment and problem solving, community affairs, and hobbies, and personal care. Now, personal care is one of the last things to go. This is the kind of thing like being able to dress yourself and being able to feed yourself. So this is very late stages of the disease. So most of the people who are enrolling in this study don't have that bad of impairment, but as you can see, we still have a nice treatment effect for either of these populations for those things that measure. One of the problems that we have now, we haven't had any treatments, so people don't really know how to talk about what does the treatment mean at the individual patient level, right? So we've started to try to design pre-specified outcomes that might have some meaning to people. And this middle box highlights one of the pre-specified outcomes that we gated for. So that means that we planned it, we said it would hit. If it didn't hit, then we get penalized for it. It is, in fact, highly significant. And it was a simple question, like how many people stay stable for 1 year on treatment or on placebo? And about 47% of people on donanemab really had no change in that CDR score for 1 year, whereas only about a quarter of people. So about half people with treatment were stable, and only about a quarter of people, if you had no treatment, stayed stable for 1 year. And so that gives a time domain to discuss with patients, because really they don't understand the CDR sum of boxes. They don't understand this IDRIS. These are meaningless scales to them, even though we use them in trial. And so what we hear patients want is time, right? You've told them they now have Alzheimer's disease, and they know they've had some impairment, but they really are asking, I want more time to do the things that I love. And so time becomes a really common way to talk about what these treatments can bring for people. This is another way to kind of think about time in a different way. And this, again, was pre-specified, pre-planned, and was highly significant. And this asked the question, these are really big clinical changes, right? So what's the probability that you're now going to go to the next worst stage of your disease? Are you going to go from an MCI, so mild cognitive impairment, to a mild dementia? Remember, dementia, you're no longer really compensating for things. Or are you going to go from mild dementia to moderate dementia or even severe dementia? So this asks that question, what's the probability that you're going to go to the next stage of the disease? And here you can see there's a 37% lower chance that's with donanemab treatment, on the green line, of going to that next worst stage in that course of the treatment. I'm going to talk a little bit about biomarkers, because biomarkers really helped change the way we've done Alzheimer's trials. In fact, amyloid scan and amyloid imaging used to be only done at the end of life, right? They were autopsy diagnoses. Now with amyloid imaging, we can diagnose it in life, and now we have tau imaging, and we can diagnose that in life. And now we're getting blood-based biomarkers, which is just that much more scalable and tractable, less cost, is more cost effective, easier to do, since it would have broader applications. So I'm going to go over a couple of those things. Again, some of these images of the tau scans are up there, but this is the amyloid scan here. Remember, we use centiloids because it's on a 100-point scale. It's like centigrades. And as you can see, on average, 100 is about what the people who are now very symptomatic with Alzheimer's disease, and that's common across the treatment arms. And tau PET here, as you can see, higher numbers are worse. And here, for the earlier pathology, you see by definition these people should have had less pathology because we put them in this bucket. But you can see the higher pathology, it does go up. And then p-tau, this is called, it's a P stands for phosphorylation. Tau is, again, this protein. It's a soluble protein, and we're now being able to measure it in blood, which is really exciting. In fact, we're now using this biomarker to enroll what we call the preclinical phase of disease, or doing prevention studies, so preventing people before they even have symptoms. So we are now enrolling and using this as a biomarker. So it's an exciting biomarker. It's new, and it's only like a couple of years old, and there still isn't actually a commercial test yet for people to use, but they're coming. And so we can use that, and we can see that generally it's a little bit higher also for the later stages of the disease. NFL, this is another protein that's been very useful in multiple sclerosis. It's been a little disappointing in AD, and it hasn't been that useful yet, but we don't see huge changes here, even between the higher pathology and the lower pathology. GFAP is an inflammatory protein. It's a marker of astrocytes. So this is another important cell in the brain, other than the neurons. And the astrocytes get really irritated with all this protein buildup, and they become very reactionary. And this marker tells us kind of how bad are they reacting. Now, it's not specific to Alzheimer's disease. So if you get brain injury from trauma or infections or anything like that, it'll make this protein go up. So it's not specific to AD. p-tau is specific to AD. NFL is not specific to AD, and neither is GFAP. So that's why p-tau 217 is really an exciting protein, because it is very specific to the disease. So I'm going to show you some data now. So on the biomarker. So this is the amyloid removal, right? So this is how many people, the percent of people that we got below. This is a specific number that measures, once you're below this 24.1, that means you're kind of in the amyloid negative. You have had all the amyloid we can measure kind of removed, so to speak. And you can see that those people with donanemab, in this earlier phase, about 80% of people got all the amyloid cleared at the end of the trial. And this is just the whole population in total. So if we talk about the whole population in total, you can see that about 30% of people might be able to actually only take 6 months of treatment and then be able to stop the treatment, which is important because it's burdensome to take patients to physician's office and sit there for an infusion, and so this would be very beneficial to society to not have to take this for your whole life. And then we anticipate, well over half of people don't need treatment more than a year. This is the p-tau 217, and so this is, again, very exciting data because this, in the placebo arm, you can see it continues to rise as the tau continues to build up and the disease continues to progress. So it's already starting at a high level, and what we like to see is that we're kind of trying to normalize it. And here we see very nice and dramatic, very early responses to the amyloid removal, and about 40% dropping down. Same thing for the whole population here. It's highly responsive. And the nice thing about, what science is supposed to do is replicate itself, right? And gives you confidence in the findings. And so we're starting to see these p-tau proteins. There's a handful of different types of them, but they're all responding, it seems, to the amyloid lowering. And so we may someday also be able to use this as kind of a cheaper way to measure response to treatment. I showed you the amyloid PET scans, but those are costly, require getting a little bit of radiation. And so it'd be nice not to have to do that to monitor treatment. So this is now p-tau. It gives us the same pattern as we saw with the tau measuring on PET scan, and that is the more p-tau you have, the more you're declining here, gray bars for placebo, and you still have high, significant treatment effects, but the relative treatment effects again are less as you wait later in the disease, and this is also true for the CDR-Sum of Boxes, so same pattern. And now this is the GFAP. So this is the astrocyte protein that gets irritated and released out into the blood. And we can see, again, it continues to rise without treatment. And now we're actually dropping it down and trying to normalize that protein. Okay, so let's talk about some of the risks of treatment, because there are risks and they can be significant. Fortunately, not for most people, but when we did the trial, you see there's a slight imbalance of death with treatment. Most of that imbalance comes from what we call treatment related. So there were 3 deaths that were thought related to treatment from the investigators, actually one from in the placebo arm. And these are what we call ARIA-related deaths. And I'll talk a little bit about ARIA in just a second. Overall serious adverse events are more balanced here, and general AEs. But you can see that treatment discontinuations with adverse events are higher with these treatments, and that's due to two main factors. This is what we call infusion-related reactions. So almost everyone who we give this drug to, they make an antibody to it, and some people, they make too much antibody and they don't tolerate the infusion anymore. And then there's this ARIA side effect that's common for all the amyloid-removing agents, and this stands for amyloid-related imaging abnormalities. So these are things that we see with the treatment. As we go in and remove that amyloid, it creates an inflammation as this particular cell called microglia go in and try to clean up and eat the protein. Hypersensitivity is just the same thing, almost the same thing as this infusion-related reactions. Now, ARIA is common in people, and you can see actually even placebo patients have ARIA. So it's kind of part of the disease. ARIA comes from the same protein that's building up in the brain. It also builds up in the blood vessels that go to the brain. And so people have these little hemorrhages, even the placebo patients. Now, they don't often have the edema part. That's more common with the treatment, but they often have these little microhemorrhages, and that's because the blood vessels are not normal. Now, when we go in and give this antibody, it's removing the amyloid from the brain, but it also removing that bad protein that's building up in the blood vessel. And so sometimes those blood vessels are weak and they've been damaged already from the amyloid buildup, and so they have these leakage and hemorrhages, and they can be severe and life-threatening. But most people are asymptomatic. So only about 6% of people who get donanemab even had some kind of symptom, and the most common symptoms are like headache and sometimes dizziness and sometimes confusion. But headache's the number one symptom. And if you had ARIA, about a quarter then of those people who have ARIA are also having symptoms. And we break it into edema and RAH, which is the hemorrhage, and then macrohemorrhage is kind of a larger hemorrhage that we are also following. The good news is that it's front-loaded in the treatment disease, so it's not going to happen. It tends to happen at the first start of the disease, and we kind of know when to monitor it most closely. And so most people are going to have their effect. If they're going to have ARIA, they're going to have it here in the first half of the year. And then it's very uncommon later in the treatment. This is the infusion-related reactions. I'm all running out of time, but they do occur. They can be serious. So far, there's been no deaths related to it, but it's an important aspect that requires like a 30-minute infusion, and then making sure that patients are watched for about 30 minutes after the infusion. So it's an hour period of treatment time once a month. And most of the infusion-related reactions happen during that infusion or in that 30 minutes after. So in summary, the Trailblazer program for donanemab that had positive phase 2 replicated very nicely in phase 3, represents the first positive study and the first replication. We see treatment effects across all the disease stages, although it's very important to treat earlier because we see much better effects. We're also starting to learn that also the earlier the pathology that you start treatment, actually also the less risks there tend to be with these ARIA aspects, because there's less buildup of protein in the blood vessels as well. So the less damage they are, the less ARIA there tends to be. And the profiles are manageable, but they're important to discuss with patients. And we know that there's a gene that people have, it's called ApoE, that puts people at slightly higher risks for this ARIA. And we now have blood-based biomarkers to measure it. So I'll stop there.
All right, thank you so much, Dr. Sims,
you.
for your presentation and for sharing the results of your work on donanemab. We're so grateful for your contributions to the advancement of Alzheimer's treatment and care, and we look forward to really continuing to follow your work. So we will now continue along to our next speaker, Dr. Ceres Elliott. Dr. Elliott currently serves as a program director for the Clinical Interventions and Diagnostics branch of the Division of Neuroscience at the National Institute of Aging. Although Dr. Elliott has been with the Division of Neuroscience at the NIH since 2008, she has also previously held other positions in the Office of Intramural Research and the Office of Extramural Research for the Office of the NIH Director from 2004 to 2008, where she was a liaison with nonprofit organizations, patient advocacy groups, drug industry, and individuals to disseminate NIH policies and programs effectively and creatively to stakeholders. Using her extensive experience in the field, she now creates evaluation and management systems for multiple research portfolios. Most notably, she co-leads the Alzheimer's Disease Research Center's program, evaluating the scientific productivity of an NIH research portfolio focused on Alzheimer's disease and related dementias. Please join me in welcoming Dr. Ceres Elliott.
Okay. Thank you for your invitation this afternoon to your virtual symposium. I think that the National Alzheimer's Buddies is an organization that our communities essentially require because you are enhancing the life aspects of our aging population. There are so many relationships that you are fostering through your weekly visits and your organizing. So much experience is being shared throughout your encounters. Thank you for your volunteerism, and thank you to Dr. Sims for speaking before me. I'm Ceres Elliott, and as Leo introduced, I am the program director for the National Alzheimer's Disease Research Centers from the National Institute on Aging. This year, the National Institute on Aging is celebrating its 50th anniversary as a federal funding institute supporting aging and Alzheimer's disease research across the nation and the world. And I'm celebrating my 20th year in public service by bringing this summary to you this afternoon. Drug trials to treat and prevent Alzheimer's disease, where we are and where we're headed. I'll just start in general, kind of defining a clinical trial. A clinical trial is a research study where we're trying to evaluate the effects of experimental interventions or tests. And we kind of believe that that's kind of the gold standard in how to bring an intervention to the public. Clinical trials are voluntary research studies, and you're asking a specific question about the safety or the effectiveness of drugs, vaccines, other therapies, or tests, or new ways of using existing treatments. We want to determine whether a treatment has a desired effect, how it's metabolized, how much should be administered, and how often. We also want to determine the side effects of how best to manage these side effects and determine if there are any interactions with food or drugs or drinks, or how these effects can be avoided. Most targets start with a preclinical kind of trial that's designed to assess the safety, the toxicity, and the pharmacodynamics and pharmacokinetic information of that target of choice. And then you have the phase 1 trial, which is a research team will give the treatment to a small number of participants and examine its safeties and actions in the body. And the main goal of a phase 1 trial is to establish the highest dose of a new drug or practice that people can tolerate, and to define the dose at which harmful side effects may begin. And if the treatment appears to be safe, then it's tested into a phase 2 clinical trial, where it involves a larger number of people, and the study team wants to know whether the treatment can safely and effectively modify symptoms or change the course of disease. In phase 2 trials, this is where researchers introduce the use of placebos, and then the results of the phase 2 studies give researchers an indication of the effective dose to use in phase 3 clinical trials. Now, these phase 3 clinical trials are larger studies that compare an experimental treatment with a placebo or a standard treatment to determine safety and efficacy. And These trials are complex, they're expensive studies, they can involve hundreds and often thousands of volunteers, and they're conducted over a long period of time. And the final phase that we have here on my chart is phase 4 studies, which occur following the acceptance of phase 3 results and provide additional information on treatment, drug risks, benefits, and the optimal use of that. And so that's just an overview and a definition of clinical trials. And I will then now briefly review some of the current AD treatments that are available. These treatments that I am introducing are full FDA approval for the symptomatic cognitive treatment of mild cognitive impairment or Alzheimer's disease. And they fall into the categories of acylcarnase inhibitors, NMDA receptor antagonists, and the last one is a combination of those two categories. And these treatments provide a temporary symptomatic improvement for some patients, but not all patients. I'll briefly discuss lecanemab, which is branded as Leqembi, and it is also an anti-amyloid immunotherapy, as the one that Dr. Sims discussed in his presentation. And it attaches to amyloid, and it prevents amyloid plaques, which is the hallmarks of Alzheimer's disease, from occurring. And the trial that allowed that was a phase 3 study is a Clarity AD trial. It had over 1,800 participants with early AD, which can be defined as mild cognitive impairment or mild Alzheimer's disease. It had a good inclusion of ethnic racial groups in the US and had 25% of the enrollment, including Hispanic and African American persons living with AD. And the results showed a cognitive clinical decline by 27%, starting at 6 months of treatment, and it decreased the brain amyloid. And there are additional side effects to this treatment as well. ARIA is also part of a side effect that is in this treatment. And since Dr. Sims discussed it, I will move along. The use of Leqembi has been approved for people with early AD with confirmed presence of beta amyloid. And there are no safety or effectiveness data at this time initiating treatment at earlier or later stages of the diseases. The physician administering this treatment for participants will have to monitor for ARIA using MRI. It's administered by IV every 2 weeks, causing the patient to go to the hospital or the infusion therapy center. The initial costs were at $26,500 per year. Medicare coverage with conditions were announced in July of 2023, and the Veterans Health Administration is providing coverage as of March 23. Lecanemab is currently being tested in 2 partially funded NIA studies that are being funded in a public-private partnership with industry and nonprofit foundations. The first one is the Head study, and the second trial is the DIAN-TU Tau Next Generation. And I'll just briefly go through the Head study, which focuses on cognitively healthy, older, at-risk adults. We kind of call that preclinical AD. In the Head study, is testing whether lecanemab can slow or stop the earliest brain changes due to Alzheimer's disease in people with the higher risk of developing the disease in later life. It's currently recruiting up to 1,400 participants, ages 55 to 80, and the participants will be treated up until for 216 weeks to evaluate the efficacy of healthy individuals with elevated amyloid and early preclinical of this treatment. The Head study is the first study to enroll participants as young as 55 years old who are at risk for AD dementia. It's the first to use a blood test to rule out people not likely eligible based on amyloid PET imaging. It's the first to target the early changes in the brain due to AD by enrolling participants with intermediate levels of brain amyloid. And it's the first to use an approach that tailored dose levels of lecanemab to study participants' brain amyloid levels. And it's the first to test an investigational treatment that has been shown to lower brain amyloid and slow disease progression in people with early AD. And if you like to learn more about the AHEAD study, you could go to their website at aheadstudy.org. They're currently enrolling across the United States and Canada at 75 locations. And if you know someone or you yourself who are in attendance that's interested in volunteering, you could call the 800 number listed here, 1-800-AHEAD-70, and speak to a representative to get connected to a study location. And the estimated study completion for this study is October 2027. Now we'll kind of talk about other anti-amyloid immunotherapy in late-stage clinical testing. One study that I will talk about is the A4 trial, which is partially supported again in a public-private partnership with the National Institute on Aging and Eli Lilly, the Alzheimer's Association, and other philanthropies and nonprofits. And it's the first of its kind secondary prevention trial in cognitive healthy older adults who are 65 to 85 who had evidence of amyloid pathology on PET imaging. And this is a randomized, double-blind, placebo-controlled phase 3 trial of soluzumab. And we have over about 1,400 participants, over 67 sites. We had to screen almost 7,000 participants in order to get people, to get the 1,400 that have enrolled. The people who were negative for amyloid were recruited into an observational cohort called the LEARN study that's funded by the Alzheimer's Association. And because of our significant investment in this study, we have enhanced data and biosample sharing for this study, and that the screening data and the biosamples are available to researchers within the 12 months after enrollment via the Laboratory of Neural Imaging. And they have processed over 900 data requests for this data over the last year. Trial data and biosamples will be made available within 18 months after the completion of this trial. As of March 8th, 2023, the preliminary results showed that soluzumab did not slow cognitive decline in preclinical AD, and there was not a slowing or stoppage of amyloid accumulation, and that the higher baseline amyloid levels were associated with a greater risk of progression to synaptic AD and a more rapid decline. ARIA was common, and the incidence of that was similar between the treatment and the placebo groups. Those are a few highlights of the current treatments and the active trials in phase 3. And now I would like to highlight the volume of current AD therapies in the development pipeline. The Alzheimer's Association publication, Alzheimer's and Dementia, Translational Research and Clinical Interventions, annually report the drug development pipeline. And in this figure that I'm showing, it's showing that there's 143 unique therapies in 2022 that are being part of 172 clinical trials. And if you have an interest in learning about these 172 clinical trials, They're available on the clinicaltrials.gov website, and you would search for trials that are registered for Alzheimer's disease. The figure also shows the number of the total number of required participants needed for these 172 trials at the time in 2022 was over 50,000 individuals that are needed. At the bottom of the chart, it shows the phase 3 clinical trials, because the phase clinical trials are the closest trials to having a target that's available in the wider population. And you see that there are currently 47 trials, followed by 94 phase 2 clinical trials and 31 phase 1 clinical trials. Also annually, Dr. Jeff Cummings and his team annually publishes a Alzheimer's disease drug development pipeline summary and review, and produces this figure of concentric circles, which highlight the mechanism of actions of the different targets, the participant characteristics that are being recruited for these trials. And in these concentric circles, they're listing the studies that are in phase 1, in phase 2, and in the smaller circle, those that are actively in phase 3. And you can see that the currently 5 disease-modifying biologics in phase 3, and you can see the numerous amount of small disease-modifying small molecules that are available in a phase 3 trial. The last 15 to 20 years, NIA has been focused on providing additional resources into diversifying the therapeutic pipeline for Alzheimer's disease. And this is first done by creating a pipeline of translational research funding opportunities. And we've been staffing our workforce to manage these growing programs and funded awards, and in partnering with other units at the National Institutes of Health. At the top here, you see the required translational processes and actions necessary for a drug approval. And this starts with early target identification and early validation, followed by assay development and screening, followed by proof of concept, lead optimization, and a candidate selection. And from these prior studies and work and actions, then the investigators are then have the data and the knowledge to turn in an investigational new drug application, and this new drug application is required in order to recruit human subjects and test the candidate into phase 1, phase 2, and phase 3 trials. And so we have built funding opportunities to help researchers and support them financially through each of these different processes of and actions during the translational process. And we use the R01 mechanism to fund early and late stage clinical trials for Alzheimer's disease. We also work with small businesses in advancing research on Alzheimer's and related dementias through our small business program and in these mechanisms at the bottom here. Secondly, we support a research infrastructure to lead in the discovery of new molecules with disease-modifying effects and enable the necessary infrastructure for a data-driven and a predictive drug development process. So again, we are building this infrastructure to map on to the processes and actions of translational research. And we are supporting those individuals that we're funding in those funding opportunities that I showed before with infrastructure that supports them in systems biology, infrastructure that could do the assay and the screening for people with who have targeted a candidate. We provide animal models for candidate selections and lead optimizations, And when that investigator has that investigational new drug application, we are providing them a clinical trial infrastructure in which they have the resources to recruit participants and begin their phase 1 clinical trials. In our International Alzheimer's and Related Dementias Research Portfolio, also known as iDrop, we have a database of funded research with nonprofit and NIH. And in this chart, I'm showing 15 years of NIH funding that supports Alzheimer's disease and Alzheimer's disease-related dementia drug discovery and preclinical drug development. Each color is a target identifier in some sort of way, such as oxidative stress, cell death, inflammation. You see in the beginning in 2008, a lot of attention in the blue was towards the amyloid beta target. And you see that during the years, we've worked to diversify the targets that are being supported by the National Institutes of Health. And this is a line chart kind of showing the same of this number of projects. You see the majority of the projects are not amyloid beta, but we are still supporting studies for amyloid beta. This is a list of NIA-supported drug candidates that have advanced to clinical development. We have 18 investigators that have gone and received an IND, that new drug application that allowed them to go into phase 1 and phase 2 clinical trials. Here is the annual trend in the number of new NIA-supported projects in phase 1 and phase 2 clinical trials. This chart is representing 106 trials over the last 15 years. And again, we're identifying the targets of interest in which these trials are trying to test. In this next slide, I'm showing the number of new NIA-supported projects for late-stage clinical trial development in phase 2 and phase 3 clinical trials. And you see that the last trials that we have supported started in 2020, and we awarded 4 late-stage phase 3 trials in 2020. Two are looking at vascular, one is looking at tau, and one is looking at amyloid beta. I just want to thank you again for inviting me to give you an overview of the National Institute on Aging's funding support of early and late stage clinical trials for Alzheimer's disease. The total number of active AD and ADRD clinical trials prior to September 23rd is 462. And you can see from this figure that we break down those trials into 5 categories: pharmacological, non-pharmacological, dementia care and caregiving, treatments for neuropsychiatric symptoms, and then a bucket for diagnostic tools, assessments, and imaging studies. And if you want to keep up to date with our active clinical trial portfolio, you could definitely search on our website, nia.nih.gov, and search for the clinical trials and see our updated figure. You could also see these 5 categories also be broken down smaller into other smaller categories as well. Overall, our goal at the National Institute on Aging is to support research that will increase the knowledge and understanding of the disease so that in the future we can select the right disease pathway for the right therapeutic agent at the right dose for the right patient at the right stage of the disease and provide a successful outcome in Alzheimer's disease treatment. There are numerous ways to stay informed and connected with the activities of the National Institute on Aging, and I hope that you follow us on social media. You can also get our weekly blogs by subscribing to our blog. And you could also know about our funding opportunities. And you can also know about the latest approved concepts that we have in the pipeline to work on identifying and funding treatments for Alzheimer's disease. Thank you.
All right, thank you so much, Dr. Elliott, for your overview of where Alzheimer's research efforts are currently being focused. I know I definitely will be signing up to get more updates from the IA. So I think we all now have like a much better idea of what the future holds for Alzheimer's knowledge and treatments. So moving on to our next event, we will be hearing from 3 professionals in the field of Alzheimer's who have experience with both the clinical care and research side. So please join me in welcoming Dr. Joseph Mazdo, Dr. Jagan Pillai, and Dr. Lauren Alving. So before we begin, we wanted to note that some of the questions during this portion will be targeted towards specific panelists. However, all panelists are free to further discuss the ideas presented by someone else if they would like to contribute a new perspective or kind of expand upon what was previously said. So now then, could each of you please briefly introduce yourself and your relation to Alzheimer's disease and dementia? And I guess we can begin with Dr. Mazdo.
Thank you very much, Leo, and thank you for inviting me to this very interesting symposium. I thoroughly enjoyed Dr. Cerise Elliott's presentation, which was thorough and current and very clear. Thank you, Cerise. I am the director of the National Alzheimer's Center. I'm a neurologist, and I've been taking care of people with Alzheimer's or involved in Alzheimer's since I was a professor at the Albert Einstein College of Medicine in New York. Then I worked I was an intramural at NIH for a while, and I joined Houston Methodist in 2014. My interest is in neuroimaging as a way of looking at the neurobiology of Alzheimer's, but I'm very clinical as well. So I see patients with different degrees of cognitive impairment, and I'm happy to say that I'm seeing more and more people who don't have any symptoms, who are completely asymptomatic, who are perhaps concerned because they have a relative with Alzheimer's, or they have found that they have the ApoE4 allele, which confers some risk for Alzheimer's, and they want to know what to do. And this is the group for which we really have the greatest hope. And I think that through your group, you can encourage people to go to a memory disorders clinic if they are 55 or older. We saw the ages at the Head trial, which we are participating in, and see whether there is something that they should be doing. So this is my introduction.
All right, thank you. Then we can move on to Dr. Pillai.
Thank you for the invitation, and it's a pleasure to be here and get to know the efforts of the National Alzheimer's Buddies session and also the previous speakers. So I'm a associate professor of neurology and a research director at the Uruvo Center for Brain Health and Cleveland Clinic. I'm a clinician scientist, so I see patients with cognitive disorders, just like our panelists here. And I also have a research program trying to understand, why do people with the same pathology of Alzheimer's disease or other kind of conditions behave differently in terms of their disease risk, disease rate of progression, outcomes, the kind of symptoms they have. They're so varied, and we need to find out, as Siri said, specific targeted treatments for each of these concerns, and that's really my focus at this point, along with understanding the risk factors that leads to these kinds of conditions.
Thank you. And then finally, we can go to Dr. Alving.
Thank you, Leo, and I too enjoyed the presentation so far, and thank you so much for inviting me here to speak. I am Lauren Alving, and I am a professor of neurology. I'm the director of the UCSF Fresno Alzheimer and Memory Center, which is one of the 10 California Alzheimer's Disease Center in California that provide centers of excellence for Alzheimer's and related dementias. I'm also the director of the San Joaquin Valley program, which is a program for medical students to train medical students in the San Joaquin Valley, which is a specific portion of the Central Valley, which is extremely underserved medically, and to train them in the Valley, and the hope being that they stay in the Valley. And so I think that has some bearing on what we will be discussing today. So thank you again.
Thank you, Dr. Alving. And so now we'll transition on to the panel questions, and I guess we can go in the same order, Dr. Mazza, Dr. Pillai, Dr. Alving, but also please feel free to jump in at any time if you would like to add on to something that someone else has said. So our first question is, please briefly summarize your work with Alzheimer's disease and dementia. How does your work contribute to the advancement of care for patients with Alzheimer's? So a similar question, but I guess if you feel free to go into a little more detail about the specifics about what you do on both the research and the clinical side.
Right. So I did already mention that we use a lot of brain imaging to understand the neurobiology of these diseases. And of course, as Dr. Elliott commented, knowing what is going on with a specific individual, personalized medicine, is critical. So we need to know, for instance, is somebody who comes to see me and is concerned about a family history of Alzheimer's. Suppose she's in her 50s, right? And she tells me, well, my mother has Alzheimer's. I have also a brother who has Alzheimer's. What do I do next? Well, what I can do now is do a neuropsychological evaluation of this person, find out how she's doing, and this is what I do. And then, frankly, I will obtain an amyloid study, or if I find that this woman is cognitively intact, I will encourage her to be in a clinical trial for people who are cognitively intact with a family history. And you know, as Dr. Elliott said, if she's in the Head study, the first thing that we're going to do is to draw a blood sample, and taken blood can tell us whether she's highly predisposed to having increased amyloid buildup in the brain. If she does, then she is likely to worsen through the years. This is nothing that is going to happen from one day to the next, but you know, in a number of years, she's going to begin to develop cognitive impairment. It's shown in many studies, including A4, and we want to prevent that, right? So the blood test could be positive or negative. If it is negative, then she will not be qualified to enter the Head study, except that we have other studies where we can obtain brain amyloid imaging, and we have found that several people who had a negative blood test turn out to have a positive brain amyloid scan. So if she does, then she will be encouraged to be in the Head. On the other hand, if I were to find some cognitive impairment, then I would go ahead directly and do an amyloid scan. Why? Because I can prescribe lecanemab once I inform her of all the potential side effects. You heard about brain edema that happens in a small percent of the people who were in the clinical trial. It was less than 20%. And in the majority of those who had brain edema or microhemorrhages, we found those things through MRI. The patients didn't have any problem. So it is only a very small minority, about 2%, who has symptoms. But we monitor those changes with MRI, and then if they develop edema or microhemorrhages, small tiny bleeds in the brain, because the amyloid is taken out through blood vessels, and the wall of the vessels is weakened, and we see both a little bit of the liquid constituent of the blood getting out, causing edema, and the cells also getting out, causing microhemorrhages. If we see those things, we will stop the treatment for a while, and then those changes reverse, and we can continue the treatment depending on how severe the changes were. If they were very severe, we rather not, right? So you see, I describe this patient because it gives you an idea of what it is I do with the patients, both in terms of clinical practice and also research, because the use of lecanemab on people who are cognitively intact is still experimental, is still within a clinical trial. So we integrate, I'm sure that, it's my colleagues on the panel, Jake and Lauren, they probably integrate their, and they will tell us about it, their clinical practice with their research. And this is extremely useful because patients are very encouraged, and their families, when they can do something beyond the medications that we other medications we have, which are unfortunately very not very useful or efficient or effective, I should say. Okay, that's the summary of my answer to this question.
Thank you, Joe, if I can call you that. This question about how does your work contribute to advancement actually made me think about how I started in this role. The NIA and NIH has done a great job in advancing our disease, what we understand about Alzheimer's disease, by having large cohorts of subjects who are carefully characterized over many years of time, and given us unprecedented insights into how the disease actually evolves over time. So much so that we have now targeted medications that target exactly the stage of disease where they might have most benefit. But one of the most surprising things that I faced when I actually started, practicing full-time, having had, an idea or a model of how the disease is, that in our patients that I'm seeing, actually there's a lot of variety. People don't often follow exactly what's the pattern of things or diseases patterns are expected. And as Joe mentioned, sometimes one test is positive, the other test is negative, or their clinical symptoms are very surprising or unusual. And there's also the question of diversity. I mean, many of the studies that we understand how Alzheimer's disease develops is on very focused, well-characterized, highly educated populations. What does it really mean in the general community that's very varied? So my work is trying to understand these kinds of unfilled questions, that it's important to understand the whole aspect of disease, how it affects a wide variety of our community, and in different ways it comes across to enhance effectiveness of medication. So the new medicines that Dr. Sims talked about are dramatic, and is doing something that we were hoping that it will be as effective now. But there's still a lot of distance to go. The effect size of these medications are not reversing any of these problems people have. And in people with some genetic conditions like ApoE, which almost constitute 50 to 60% of people with Alzheimer's disease, have a high risk of side effects on these medications. So there's a long way to go. And that's where the focus is on the kind of work, both clinical and research, that I'm doing. So this is a very exciting time to be here, and I'm thankful, I have an opportunity to do these things.
I'll go ahead. Thank you very much. And I'm going to, it's a little tricky for me. I'm going to kind of combine some of my answers to these questions. I think the point of our California Alzheimer's Disease Center, which I said is one of 10, we are the only one in the middle of the state. Most every other one is either in the kind of in the Bay Area or in the Southern California, LA, San Diego area. And so we have a wide range of geography to cover, and it's very difficult. So what our goal is to bring the center of excellence into the San Joaquin Valley. But we can't see everybody. I mean, that's impossible. And so what we really focus on, and we're doing this in parallel with the main campus, UCSF, is to train primary physicians, primary providers in recognizing dementia, mild cognitive impairment, helping to start to sort the Alzheimer disease versus other. We're, as time goes along, there are going to be better and better tests. Blood tests are becoming available that may be able to distinguish, but even then, you can get tripped up. So we're working with UCSF in training our residents and our medical students in kind of basic evaluation of patients with dementia and how to recognize someone who's pretty typical, someone who's probably MCI, and someone who's definitely different, so that then as these treatments develop, they'll be able to help get these patients into the care they need. I think the main thing that we deal with is we don't have as many of the people who are high socioeconomic and have the mild symptoms when they come in. We're trying to get our primary providers to recognize when patients come in with early symptoms and not kind of just say, well, that's pretty much normal aging. We're trying to get them to say, okay, we need to decide if they need to have further referral for workup of mild cognitive impairment. As these treatments come out, we know that they're the earlier you treat, the better. So if people in the community are not recognizing these patients or are telling them they don't need to be seen, and this happens particularly in underserved communities, then they're going to be not getting the treatments that they need early on. So I'll stop it there, but I can, I'll have answers to some of the other questions as well.
Leo, and if you would allow me a second to expand a little bit on my answer, because I felt that for the bodies that Alzheimer interested your companions in this interest that you have, your bodies, it's important to understand how one of our memory clinics works a little bit. That's why I gave you this example of this patient, right? But just to amplify a little bit how we contribute with our work to an understanding of Alzheimer's disease, we've done, since my times at Einstein, we've done many studies that have contributed to where we are now, looking at therapies that are effective. But there is an area that we are working on, and we've been working on now for about 4 or 5 years, which is brain inflammation in people with dementia, or cognitive disorders that lead to it. So we are using imaging again, and we are using blood biomarkers and cerebrospinal fluid to see what happens with the brain in older people. Because as we get older, our immune system, immunity becomes a little what we call dysregulated. What does that mean? It means that it doesn't work as well as when we have a mop of black hair like you do, this could be one of the reasons why we see these diseases more in older folks. So we are using brain imaging to look at inflammation, and in a disease that is called frontotemporal lobar degeneration, that is not Alzheimer's, but is in the same group of neurodegenerative diseases where neurons are being lost slowly over time. We have found that areas of the brain that are sick expand towards areas of the brain that are healthy. And in the border, right in the border is where inflammation is greatest. So it's possible that inflammation is playing a really important role in the progression of the disease. And you know, we are very interested in looking at that. We are also working, you know, the Texas Medical Center, where I am, has a number of institutions that are working on Alzheimer. One of them is the Baylor College of Medicine that is next door to us. And I'm working with a researcher from Baylor, Dr. Josh Schulman, and both of us are doing what Dr. Elliott mentioned that is so important, which is to look at precision medicine in this disease. So what does that mean? It means that we are not using, you know, a size-fits-all approach, okay? You come here with a label, Alzheimer's, we'll give you this drug. We are at the stage where we need to know what's going on in the brain, not labels, what's going on in the brain. And we learn that by doing imaging. And we also look at the entire genome of the person and are trying to define what is best for each individual. So that's another area where we are advancing Alzheimer research.
Great, thank you to all three of you. It's so interesting how each of you treats the same disease, have such unique experiences and insights to bring to this discussion. So our next question is, how have the recent breakthroughs in new Alzheimer's treatments affected your work or research? So many of the things that Dr. Elliott talked about earlier in her talk. And if possible, we'd love to hear some stories of your experiences.
Since I've been speaking so much, maybe Jagan, you want to go ahead?
Yeah, sure. You know, when I think about the recent breakthroughs, in my mind, there are two big ones. One is our amazing ability to actually make a good diagnosis using the biomarkers that are currently available. That is using either MRI imaging that are highly focused, measuring specific regions of the brain, you know, CSF or cerebrospinal fluid biomarkers of amyloid, phospho-tau, or alpha-synuclein. These biomarkers dramatically improve our ability to make an accurate diagnosis and provide appropriate care. The second biggest big breakthrough is, of course, the new anti-amyloid therapies that have shown effectiveness in phase 3 clinical trials, and they're improving clinical outcomes for patients when they have been for about 18 months or so. So from the patient perspective, I think I feel very good in being able to give a clear answer as to what is going on with them. In many cases, more than I used to before. So that's something I think patients and families really appreciate, and the clinicians in a great position to actually make a clinical impact and making some life decisions that are important for them. In terms of medications, I think families are, I mean, this is a very new medication option, lecanemab, we talked about it, it's just approved last year, so it's just being rolled out in the clinics, and we have about 30 to 40 people on this medication. So we're still trying to kind of wrap our kind of heads around what this means in terms of impact. We don't know, what this medication is going to do. And after they finish 18 months of the medication course that was approved for the clinical trials. But I'm starting to understand the challenges of using the medication. One is that even if you have a clear diagnosis of Alzheimer's disease, you really need to meet some specific inclusion/exclusion criteria. One is safety for using the medication. That means they cannot be on any anticoagulant or a blood thinner when you use these anti-amyloid therapies because of risks or side effects. Some of our patients may not qualify because they are on anticoagulant because they have a atrial fibrillation or had a deep vein thrombosis. These are pretty common conditions with age. The second reason may be that they have an ApoE4 gene that puts up at a different risk profile for side effects. or even something as practical that, the medications or IV infusions, they have to come into the hospital and get this every 2 weeks for a year and a half. So that actually is a dramatic change in how you have to plan your life and set your priorities around that. So how do you make decisions there? Families are struggling with that. And how long is the drive to get here? Or how about my plan to see my grandchildren? They're in a different state. How long could I stay? How often should I get an MRI if I'm claustrophobic? These are all these practical issues that kind of whittle down the people who actually are going to benefit from this medication because of the commitment needed for using these things. So we are still trying to figure out a way in the role of these medications, but as I mentioned, the fact that there are new options, the fact that there are new tools to help patients and families make better decisions, I think is a huge step, and that's pretty exciting.
Okay, I'll go next. And I agree with a lot of what Dr. Pillai was saying. I mean, I think one of the differences is now maybe we can get people into our clinic who are a little earlier along in the process because, people no longer say, well, there's nothing that can be done. They realize that there may be something that can be done. And so we're going to start to see that. I think in our valley, we deal a lot with the socioeconomic issues. Not only do some of the social determinants of health get in the way of people coming in, they get in the way of people, well, they may be driving some of the disease processes in our folks, and they may get in the way of them coming in. They will also get in the way of them making a decision whether or not to pursue the workup and or the medication for some of the reasons that Dr. Pillai mentioned, such as, they have to drive from wherever it is, to come in every couple of weeks to get the infusion. B, they may not be very familiar with healthcare, and they may not really, I wouldn't say some of them don't trust it, but some of them just are like, this is so foreign to me, I don't want to be doing this. Other people, the cost is an issue. If they're covered by Medicare and they have a copay, they may think, okay, there's nowhere I can go, but there's ways to help them. And I think that's one of the things in terms of, you mentioned the training of medical students in this setting. I mean, I think that's one of the things that we work really hard with our medical students is to understand the socioeconomic conditions that surround all of what they do. And in this particular case, they have to understand what it is that's preventing patients from getting treatment or seeking treatment, and start to think about how they might change that.
Thank you. And in the interest of time, I think we'll actually transition over to questions in the chat from our attendees. So this is a question from Kate. How far out are we from being able to halt the progression in full once diagnosed with AD? I understand lecanemab slows progression by 27%, but how long until we can stop progression in full? And I guess anyone can jump in and answer this question.
Yeah, I think I put something in the chat already. Which is that number one, the question is well informed, and that is exactly what happens with lecanemab. 27% in the 18 months of the trial. So it's possible that the difference is if we had followed those patients longer, would have been greater. So it's not negligible. It's an effective medication, but you're speaking about something else, which is stopping the progression, which is what we would like, really, not just to slow it down, but stop it. And the point I made there is that it is much more likely that we may be able to prevent the onset of the disease if we decrease amyloid in the brain using these medications like lecanemab, in people who are still in the so-called pre symptomatic stage. What is that? Is before when the person has already brain amyloid buildup, but they are completely cognitively okay, which happens all the time, right? You can. That's something that is important to understand. It's important to understand that people associate having brain amyloid with being impaired. No, you can have brain amyloid, excess brain amyloid, and be okay for quite a few years, actually. So that is the stage when we can, using this medication, we can be most effective. And this is something that was shown in experimental animals a number of years ago. Dr. Brad Hyman from Mass General has shown us this in mice very nicely. He speaks about an amyloid-dependent stage, which is when the mice have only amyloid buildup, not tau, which is another protein that, if we had time, we would be speaking about. That is the moment when we should act. And that's why it is so important that people are encouraged to take care of themselves before they have symptoms.
Okay, then another question in the chat from Ramsey. What would be your advice for newly diagnosed patients and their families?
Anyone else?
I think, when you say newly diagnosed, the question is, how was the diagnosis made? So make sure that the diagnosis was made that it is truly Alzheimer's disease and not some other sort of dementia, and then have a very careful discussion with either your doctor or a specialist, depending on who made the diagnosis. If your doctor's a specialist, great, about whether or not the new medications are for you and what other types of changes might need to be done. Make sure that all the other treatable causes of memory loss might have been addressed, such as vitamin B12 levels and that sort of thing. So when you say diagnosed, I want to make sure that the diagnosis had covered all the other possibilities, because as was spoken about and shown earlier, people can have amyloid in their brain and not necessarily have symptoms from that. So you really have to distinguish. But if there is truly amyloid, then you have to decide whether or not you want some of these medications. And depending on where you live, there may be somebody who does it in your neighborhood, or you may have to travel to a more specialized center to have those discussions, at least at this point in time. And that's going to change as these medications, people become more familiar with them, and as the diagnostic tests become more and more available and easier to use, as blood tests roll out and that sort of thing.
Dr. Pillai, I know that you're also act as a clinician, so wondering if you have any advice for newly diagnosed patients and their families.
I think Lauren covered it very well. I think the two challenges are, one is to make sure they have an accurate diagnosis, and I think the expertise of the physician plays a role there. It's still a clinical art, even though there's a lot of biomarkers, because a lot of people can also have mixed pathologies. Interpreting biomarkers is still challenging for a lot of primary physicians, and having access to them. The second is, medications. But I really emphasize that there is a strong role for non-pharmacological ways. Medications are one part of the puzzle, but they don't cure the problem. People with clear goals as what they want to do, given they're facing a new reality. People, there is significant family and community support, and who have very good control of their medical comorbidities. People who have a clear, a schedule and a physical activity program, so their physical status is pretty good, and their safety concerns are being met, so they don't get hospitalized for avoidable reasons. These things actually make more impact on the patient's quality of life and goals than just medications alone. Medications are supportive, but they're not yet a complete answer to how to live a quality life that gives you and your family the most satisfaction.
Thank
I
you.
completely agree with Dr. Pillai and Alvin's comments. Very, very good. One point that I would like to make is that we are here in the Houston area. We are working for these new medications with infusion centers that are not necessarily academic medical centers. We like to have patients go to centers that are close to where they live. Houston happens to be very spread out, as you know, Leo, and we don't want them to be, having to spend a lot of time traveling between their home and the place where they are being treated. And in this day and age, there are infusion centers for cancer, for a number of other diseases. So this is not new. We are not doing something in neurology that is groundbreaking in a way. Our colleagues in internal medicine, oncology, and so on have been doing this for a while. It is true that primary care doctors feel a little uncomfortable about these therapies yet, and we are trying to work with our colleagues to teach them as much as possible. About these medications, which have important side effects, so they cannot be used carelessly. But at the same time, the side effect profile, for instance, is much better than the side effect profile for an oncology, for a cancer drug. We can use these medications effectively, and I love the comments of Dr. Pillai and Dr. Alvin about the whole care of the patient with dementia is so important. And that's one of the things that we always try to do here. And, also being mindful of the needs of populations that are understudied, underserved. As Leo, Houston is a minority city. And, I have all kinds of people who were represented actually in the clinical trial on these medications. And we've been able to provide them the medication, people of all kinds of, in the economic scale, of all kinds of resources. And that's very nice. So, the company has been great. I think everybody is trying to make an effort to make sure these medications that are effective are available to everyone.
Thank you. So with that question, I think we'll conclude our physician scientist panel. Thank you, Dr. Mazda, Dr. Pillai, and Dr. Alving for sharing about your work and providing insight into the new findings and treatments that are continuously evolving dementia care. We also want to thank everyone in the audience that submitted questions. Unfortunately, we have to move on to the second part of today's discussion. However, please feel free to continue to use the Q&A function or the chat function to ask questions for our panelists here. Although they will be unable to answer the questions live, they can choose to respond using the chat function, as Dr. Mazda has already been doing. So we will now transition to part 2 of the symposium. So to begin that, I would like to welcome the Chief Diversity, Equity, and Inclusion Officer of the Alzheimer's Association, Dr. Carl Hill. As a leader in the fight against Alzheimer's, Dr. Hill oversees initiatives to strengthen the association's outreach to all populations. In this role, Dr. Hill is responsible for driving association-wide messaging and mobilization efforts addressing systemic health inequities in treatment, clinical trials, and research. With support from the National Institute on Aging, Dr. Hill led the association's work to convene the first national conference dedicated specifically to addressing disparities and promoting equity in dementia science. Dr. Hill also develops cross-functional partnerships with organizations to advance Alzheimer's and other dementia awareness efforts, and to deliver disease education to those who are disproportionately impacted and underserved. The floor is yours, Dr. Hill. Thank you for being here, and we look forward to hearing you speak.
Okay. Oh, thanks so much. So happy to be here. Leo, thanks for the invitation. And it's an exciting National Alzheimer's Buddy Symposium. Let me pull up my slide here. I was playing around with this. I think in lieu of my PowerPoint slides, I'll just respond a bit to some of the discussion that has been had, which I think has just been very informative. And so, I'll just start by saying I'm really excited to represent the Alzheimer's Association here, which is the leading voluntary health organization in this space. And so it's really great to have an opportunity to work with the National Alzheimer's Buddies organization with your 40 plus college chapters and your student volunteers. I wore my college shirt today here at Morehouse College, not only because of Black History Month. Morehouse College is a historically Black college, HBCU, but also because of your work and what you do with dementia residents. So big salute, and hoping that we can have a chance to talk in the future about developing a partnership. And so, just as I mentioned, the Alzheimer's Association, our work is really about community and science. We work collaboratively in many different spaces to advance care and support and research across the country. We have over 75 chapters working in communities to advance this, and second to NIH and Dr. Cerise Elliott's National Institute of Health. We're the largest nonprofit funder of research of dementia science in the world, and so we're fully in this in a translational way, looking to take findings and incorporate into useful resources for people. And I think that diversity, equity, and inclusion, we've heard so much about those words. Has been in the news lately, but I certainly think that DEI is fundamental to our understanding of Alzheimer's and other dementia in all people. And just thinking a bit about diversity, equity, and inclusion, certainly people come to this disease, this umbrella term, dementia, and all differently. So diversity is really important, including those different pathways. I thought Dr. Pillai had a wonderful discussion of some of the challenges with eligibility and getting people to participate, getting people access to the treatments. And then equity, I think, is the road to equality, right? If the goal is that everyone has a fair chance at accessing these treatments or accessing the resources that the Alzheimer's Association has, then we have to think about what they need. What are their unique needs, right? And that is either language or taking the trial to the community so that people don't have to deal with transportation in those ways, or stigma. Not all people are afraid to participate in a clinical trial, but some people are. And so giving them the assurance that their participation will be protected, I think, is so important. So I think diversity, equity, and inclusion is fundamental to this work that we're doing, and I think we certainly have to pay very close attention to that. Well, we've discussed at length some of the promising treatments. I thought Dr. Sims had a really good level-setting discussion of Lilly's particular treatment and how it reduces the antibody reduces amyloid and the effect size, which was debated in the panel session. I thought it was a really good debate. But access, giving people access to the treatments is really important. And then also, knowing that the treatments are effective or safe, effective and safe in all communities, all populations. I think that's a challenge that didn't come up in the discussion, and one that I'll bring up in just a bit. What's also, I think, been interesting, in addition to these new treatments, is a special report that the Alzheimer's Association developed and led in 2021 called Race, Ethnicity, and Alzheimer's in America. And, this was powerful because, this is the first time ever that there was an intentional work to include Asian American Pacific Islanders, Black African Americans, Hispanic, Latinos, Native Americans, and white Americans, in one national representative survey, right? And so what we did was survey U.S. adults and then also Alzheimer's caregivers, and we wanted to get a sense of, some of the racial and ethnic differences as they relate to knowledge of Alzheimer's and dementia, just fundamental knowledge, access to care and support services, trust in research, right? That was kind of debated in a panel session about whether people trust it. Some people do, but we want to understand that trust, interest in clinical trials, and then the existence of maybe even discrimination and how that impacts care. And we wanted to do this because we know there's a disparity in this Alzheimer's and other dementia crisis. Almost 2/3 of Americans with Alzheimer's are women. Almost 2/3. Black African Americans and Hispanic Latinos are more likely than whites to have Alzheimer's or other dementia. Black African Americans 2 times more likely, and Hispanic Latinos 1.5 times more likely. And I said Alzheimer's or other dementias, right? Because there are other types of dementia that are important as we think about disparities in dementia. And so, I kind of think about, these disparities and, how they are either or both fundamental or unique to, specific populations. And, we know fundamental, people need access to information, awareness, access to the treatments. That's so important. Unique, is, maybe some thought of, whether, genetics plays a role. We heard a bit about the ApoE4 gene and, other, kind of genetic, characteristics that put people and maybe even populations at risk. Research has shown us, is beginning to show us more and more that genes, don't explain the disparity that we see. There was some research presented at our Alzheimer's Association International Conference in 2020 that adds to this body of literature that shows that, maybe, the ApoE4, may not explain, in this case, Hispanic Latinos, may not explain the disparities that we see. So we look at other factors, as was mentioned in the panel session, as like social class and dementia. One study we saw at the Alzheimer's Association International Conference showed that sustained low wages in midlife, right? So sustained, low earnings in midlife are associated with faster cognitive decline, and we heard earlier that everyone who develops Alzheimer's or another dementia passes through that mild cognitive impairment stage. So, resources really matter here. They're very important. And then there's also stress, right? And so stress, plays a role in how people, cope with hardship. They may cope with unhealthy diets or turning to, alcohol and other substance abuse to cope with that stress. And, racism and racial discrimination is categorized as a stressor, right? And so it's really important to understand the non-pharmacologic interventions, or, thinking about the factors that are in the social sphere that could put people at risk for Alzheimer's and dementia, and really over their life course. I think, with this opportunity, this work with the National Alzheimer's Buddies is so awesome, because we begin to think about brain health over the life course and the things that, people engage in with their lifestyle, their nutrition, their physical activity, their coping with stress, which could have implications for their risk for Alzheimer's or another dementia later in life. Well, just moving back into that special report that I think was so important, the 2021 special report on race, ethnicity, and Alzheimer's in America. We found that more than 1/3 of Black Americans and nearly 1/5 of Hispanic and Asian Americans believe that discrimination would be a barrier to receiving Alzheimer's care. That's really important, right? Because what we've heard is that these treatments are for, a certain, phase along the unfortunate dementia journey. And if you miss that phase, these current treatments, would not be effective. So people need to feel like they belong in the Alzheimer's and other dementia care system. Also, we found that half of Black Americans report actually experiencing healthcare discrimination, and that 2/3 of Black Americans believe that medical research is biased against people of color. This is a really interesting finding because what we heard earlier from Dr. Pillai was some real, I think, practical, real world, barriers to people's participation. There's not a coordinated campaign to exclude people, but there is an acknowledgement that there are, certain barriers that keep people out of these trials, that we've got to do more, to get people in. Last, only half of Black Americans trust that a future cure for Alzheimer's would be shared equally, regardless of race, color, and ethnicity. And so this was done in 2021, and we've got treatments now that are available. And as my colleague mentioned on the panel session, we're learning, now, that there are factors that keep people from accessing these treatments because of where they live or their health literacy, really knowing that they exist and when to get them. And that's so critical and important. So we really got to do more to change this, what I call this, lack of inclusion. Knowing that less than 5% of Alzheimer's and other dementia clinical trials include non-whites. I'll say it that way. So and we're discussing race and ethnicity because there are racial disparities, for Alzheimer's and other dementia. So less than 5% of trial participants are non-white, and we've got to understand, more about this and how to include eligibility requirements that embrace, I think, the broader population health and allow more real world participation from that perspective. So we at the Alzheimer's Association have a call to action, really 4 important points. One is certainly more multi-level health disparities research. I think, focus, as Dr. Elliott showed on her wonderful slide, the number of targets and the ways that they are diversifying the pipeline to understand Alzheimer's and all dementia. So multi-level health disparities research, more representation in health systems, or to say it specifically, more, people who represent communities that we'd like to serve and include, right? And so that may mean exactly what the National Alzheimer's Buddies organization is doing, getting, into, colleges. Hopefully you're working with historically Black colleges and universities, Hispanic serving institutions, tribal colleges, to have representation there, so that, students can learn about, professions in Alzheimer's and other dementia, research and care, and go into this and certainly represent their communities in this space. More, cultural competence, maybe even it's humility, in dementia care and research, because in our survey, our 2021 survey, we found that in this space of, discrimination, perceived discrimination, Black African Americans and Hispanic Latinos said that their providers were not listening, right? So could you imagine, taking your loved one in to have an assessment and to hear or to feel like you're not being heard, right? That's so critical and important. And then I'll close here with our last call to action, and that is participatory engagement with national and local organizations to build trust and pursue equity. And as I mentioned, equity is so important because we're trying to give people the resources that they need in the way that they can best utilize them. That's so critical and important. And in pursuing this equity, we take on and acknowledge the power of partnerships. Working with national organizations that have a local footprint. National organizations like the Black Nurses Association or the Hispanic Nurses Association they have chapters all around. And I mentioned that the Alzheimer's Association has 75 chapters around the country. So, our North Star best case scenario is that our chapters can work together locally in Atlanta, in Los Angeles and in St. Louis and all the places where we have chapters to get information about Alzheimer's and dementia, get information about donanemab, or information about all of the wonderful resources that are available in the ways that people can best use them. And we know certainly that we've got to pay very close attention to the power of trust and making sure that the Alzheimer's Association is trustworthy, right? So that we can work together with these organizations to get our information out. I had a wonderful slide, that showcases our partners, but we've got to do more than show slides. We've got to work together in local context to get people the resources that they need. It's the third day of Black History Month, and so we're really excited about working with the NFL Alumni Association. Next week, we'll be in Las Vegas with a conference that examines the various risk factors and how they contribute to the disparities seen among Black African Americans and men, Black African American men, really honing in on the power of lifestyle, right? And so, again, important to know that there are pharmacologic treatments, but also we have to think about Alzheimer's and other dementia from a life course perspective, right? So how can people, again, manage their stress, pay attention to their physical activity, and maybe even adopt the Mediterranean diet, high in fruits and vegetables, low in saturated fat and red meat, over their life course to really love your brain, is what we call it with the Alzheimer's Association, or certainly protect your brain health, really important. And then another way that we're working in communities to get people the resources that they need in the way that they can use them, that's health equity, is a collaboration with a production company, the Garrett Davis production. We created a stage play called Unforgettable, and this is about Alzheimer's caregiving, crafted to educate and entertain in ways that resonate with audiences that have been underserved, right? And some people can certainly hear a lecture like the ones that we're giving at this wonderful symposium. Other people really walk away when they're entertained. And in this stage play, we include information about Alzheimer's and dementia, the importance of participating in trials, how to access the resources that the Alzheimer's Association has, their local chapter. And so our first show for 2024 will take place in Miami, in Florida, March 15th and 16th, where there's been a lot of discussion about DEI. We're really excited about going there to provide resources to do all that we can to close this health disparities gap by giving people information, right? And so as I close here, we know that if we develop a treatment by 2025 that delays the onset of Alzheimer's by just 5 years, just 5 years, 5.7 million people expected to develop Alzheimer's in 2050 would not. That's a real opportunity for us. And when we think about treatment, again, it's the span of treatments, drugs, information, awareness, interventions, ways that people, can certainly, delay the onset. We have an opportunity to really improve public health. And what we know is that, equity is that everybody gets a chance to be, in that number, in that 5.7 million number. And to do that, we've got to get people the information, the awareness, the recruitment, to clinical trials in the ways that, the ways that can be best effective for those populations. And I like to think that equity is along the path to equality. We can't get to equality without equity and really understanding how best to get people the information that they need. And I'd like to think that equity has been a part of Alzheimer's research from the very beginning, right? And so we know Alois Alzheimer's, early 1900s, had a provocative, I think, research question. When he posed that, the hypotheses that, some of the cognitive impairment that he was noticing among older adults was not, only because people were growing older, that it was due to, biological changes in the brain. And he recruited, a young Black African American scientist who was born in Liberia in Africa and attended an HBCU, just like Morehouse, attended Livingstone College in North Carolina. He was the first African American to finish Boston University Medical School. And because of some of the discrimination that he experienced in the time, he was unable to start a research career as he wanted to. But he became very good at conducting autopsies, performing autopsies there in Boston. And he was recruited by Dr. Alzheimer's to work in his laboratory to help him identify what we now know as Alzheimer's pathology, right? And so, I would like to think that Alzheimer's disease research is Black history, and Black history is Alzheimer's disease research. Dr. Solomon Carter Fuller had been there from the very beginning, and we have to remember that, as we think about the new treatments, we think about new information, we think about giving care, caregiving, and all of the wonderful innovations that come about. That we have to, certainly include all populations and think about the merit, the strength, the centrality, I think, of diversity, inclusion, and certainly health equity, getting people the resources that they need, particularly those that are disproportionately affected, like Black African Americans, Hispanic, Latinos, because that is fundamental to protecting public health. Right. And I'll stop there. Really excited about today's symposium. Thanks for the invitation, and looking forward to hearing the wonderful discussion.
All right, thank you so much, Dr. Hill, for giving honestly, such a powerful talk. Considering the sociocultural factors that you mentioned, especially diversity, equity, and inclusion is really so important when working with Alzheimer's and dementia. So thank you for spearheading the association's efforts to reach underserved communities with all this information, education, and support. And actually, as we transition to our panel on addressing disparities, we would actually love to have you stay on and participate if you would like. But
absolutely, Leo. Absolutely.
All right. So then in that case, for our final event, we will be hosting a roundtable discussion on implementing more equitable practices in dementia research, community education, and care. Our five panelists each offer an incredibly unique perspective on this topic based on their work and lived experiences. So please join me in re-welcoming Dr. Hill and also welcoming Dr. Sarah Biber, Dr. Jennifer Lingler, Ms. Melissa Sanchez, and Ms. Katie Scott. And again, we want to emphasize that although some of the questions during the discussion will be targeted towards specific panelists, everyone is free to further expand upon any ideas presented. So that being said, could each of you now please briefly introduce yourself and your relation to Alzheimer's disease and dementia? And I guess we can start with we can go Dr. Biber, Dr. Lingler, Ms. Sanchez, and Ms. Scott, and Dr. Hill.
Hi, everyone. It's so nice to be here with all of you for this. Thank you for the invitation. I'm Sarah Biber, and I'm the Executive Director at the National Alzheimer's Coordinating Center, also known as NAC. So NAC serves as the centralized data repository and data collaboration and communication coordinating center for the National Institutes on Aging's Alzheimer's Disease Research Centers program. That currently consists of 37 centers from across the country, and we collaborate really closely with those 37 research centers to collect standardized longitudinal ADRD data from research participants, and we work to make that freely available to researchers basically around the world to try and advance Alzheimer's research and discovery. So Alzheimer's is obviously, we're hearing about today, and folks are well aware, a devastating condition, impacts tens of millions of people around the world. So yeah, contributing to the fight against Alzheimer's is a challenge that is also deeply important to me personally. So I lost my dad to Alzheimer's prior to the pandemic. And also it's one that I find intellectually really stimulating and rewarding. So very happy to be here with you. Thank you.
Good afternoon, everyone. And thank you, Leo and Jillian, and congratulations on putting together such a comprehensive and really timely symposium. It's just been phenomenal, and it's wonderful to see so many attendees hanging in there for this final portion. My name is Jennifer Lingler, and I am the Director of Education and Engagement at the University of Pittsburgh Alzheimer's Disease Research Center, which is a center that falls within Dr. Elliott's program within the Alzheimer's Centers Network, and is one of the sites that contribute data to NAC that Dr. Bieber just described for you. Before becoming a researcher and having this role at our Alzheimer's Center at Pitt, my clinical background is in geriatric nursing specifically, and so the care of individuals and families affected by dementia syndromes has long been a clinical passion of mine. More recently, it's taken a turn for the personal as I watch my father-in-law struggling with dementia. And so those are my main ties, and I very much look forward to this this panel discussion to follow.
Good afternoon. Thank you for having me today. Leo, excited to be back. I know I spoke to the local Houston chapter of the National Alzheimer's Buddies last year, so really excited to be with all of you in all your chapters today, and just really commend you all for the work that you're doing and the attention that you're giving to this disease, really at this kind of juncture of your life. So congratulations on that. So my name is Melissa Sanchez. I'm the Texas Public Policy Director for the Alzheimer's Association. And so I work with our chapters in the Texas area to ensure that Alzheimer's disease and other dementias remain a priority at our state capital and at our national capital in Washington, D.C. And so that means working with our hundreds of advocates across the state, across the country, with the other chapters of the Alzheimer's Association, to really use the power of grassroots advocacy to drive policy change with our state legislators and our members of Congress. Ensuring that Alzheimer's remains at the forefront of their minds when they're talking about bills, on the floor of the House or the Senate, when they're discussing or coming up with bill ideas in between sessions, that they're thinking about, what is needed in the Alzheimer's community, what can we do to prepare our health systems, our state, for what's coming down the pipeline, whether it's regards to treatment, caregiver support, increasing, a state's investment in the disease. And the work that I do it's personal for me, as well as a lot of the other panelists have said. I lost my grandmother to Alzheimer's disease in 2011, and then my grandfather in 2013, both on my paternal side. And then, so it hits close to home, when you really understand what the disease does to loved ones, but also to the caregivers. So happy to be here today, and I'll look forward to our discussion.
I'm Katie Scott. I'm president of Care Partners. Care Partners is a Houston area nonprofit organization that provides a variety of support services for families of older adults, but we do have a lot of programs in particular for families affected by dementia. We have one-on-one consultation programs, we have education, frankly, that we partner with the Alzheimer's Association on in so many different ways. We have support groups, but then we also have free and low-cost respite programs throughout the greater Houston area, and we serve about 2,500 unique individuals every year through 35 free volunteer-led respite program sites, as well as our Dementia Day Center, which is a host site for National Alzheimer's Buddies here in Houston. So very happy to work with you all again. I did not wear my Rice t-shirt, but I am a Rice graduate. I was going to try to run into my closet to go get it. But my path, actually, I got into this work not because of personal connection. I got into this work because I got a job after college and fell in love with the population and saw the pain that families and individuals went through when dementia was kind of creeping into their family life, whether it be an official diagnosis or otherwise. I saw the isolation that the individual experienced and just how families felt so lost. And so, I'm kind of on the care side, not on the research side. So that's kind of the perspective I bring to this group today.
Great. So moving on to the next question. For most of you, besides DEI is not the primary focus of your work. So why is addressing disparities so important, and how have you seen these issues appear in the work that you do?
Well, I can take it from the care side. So I really appreciate Carl bringing up this concept of cultural competence, right? A lot of what we see in the care side is very cookie cutter. We have created long-term care systems, supportive service systems that is supposed to be a one-size-fits-all. But we have all been in situations where we didn't feel connected to the person that was supposed to be helping us. And if I don't feel connected, I'm not going to access the resources. And so cultural competency is extremely important for us to understand how are we serving these families? How do we serve them as a unit and then serve each individual family member uniquely? And so, it has, and I will be honest, Care Partners, this has not been something that we've really looked into. It's only been the past couple of years where we've said, look, this is Houston. We have a very diverse group of individuals here. We're the most diverse city in the country. We need to figure out how do we reach different populations and really think about cultural competency when we're developing programs.
Yeah, and I'll go next. So I think in the policy, because really that's my background of work is we really, and I think Katie touched a little bit on this, and I know Dr. Hill did too, is just access, where we see issues of equity and kind of a really playing a role in access to healthcare and access to quality healthcare. And then there's even a bigger kind of gap when you look at dementia care. So I know in the Alzheimer's Association, it's a priority at the national and federal level to ensure that there's equity of access when it regards to healthcare, that access to information, even just your basic level information, talking about risk reduction, brain health, the entire life course of the disease, ensuring that is always something that's being considered, right? Is that there is an equity and access to caregiver support. So not just focusing on the person with the disease, but also those who are providing that care for them. There is a disparity in the support that caregivers from underrepresented communities that they have access to, that they feel that they can connect to, as Katie said, that they trust that source. So these are all factors that I think really play into the work that the Alzheimer's Association is doing at both the federal and state level.
And if I could add, Leo, I tell you, Melissa and her colleagues are doing a wonderful job advocating, in DC for more resources, as it pertains to, this equity and providing, competent, care, as Katie mentioned, so, Melissa and her colleagues, advocated in DC and developed the ENACT Act, which for the greater part of 2 years we were getting the word out to representatives, and it increases resources at the federal level to NIH, to NIA, where Dr. Elliott works, for more resources for researchers to hire community engagement staff, to work in communities, to test various ways to be more inclusive, or to provide what I think is really important, culturally competent recruitment, because resources matter here, in terms of being able to pursue equity in this way. So just want to give a big shout out to Melissa and her colleagues for getting that ENACT Act passed at the federal level.
Dr. Linkler or Dr. Biber, would you all like to share as well?
Sure. Yeah. So I mean, there are so many important reasons for the focus on DEI and Alzheimer's and related dementia research. All the reasons folks have mentioned, and for starters, right, the United States population is ethnically and racially diverse, and we need to be able to ensure that research studies are more representative of the U.S. population, so these results can be generalizable to all patient populations. So we know that Alzheimer's and other dementias disproportionately affect Black Americans, Hispanic Americans, American Indians, Alaskan Natives, members of the LGBTQ community, and women. And so we really have so much that we need to learn about these health disparities and how we can address them. We also know that diagnosis and treatment of ADRD is delayed in minoritized populations due to limited access to healthcare, lack of insurance, discrimination, in some cases poor healthcare literacy, et cetera. And so, we're really, there's lots and lots of reasons. I think that the ADRC program, has an incredible opportunity to play a critical role in really being able to uncover the various factors that are contributing to disparities in Alzheimer's and related dementias. And the program has already collectively contributed to important discoveries in this area, and there's an exciting opportunity to build on these successes in the future.
Really well said by everyone who's spoken so far. So I'll just point out one other thing. As we're, looking at the screen and you see these white faces and, wondering what's this, middle-aged white lady doing in this space, advocating for increased representation, racial and ethnic representation in Alzheimer's research. And I think that what we really have to remember, what can't be overemphasized, is how poorly we've done as a field in getting adequate racial and ethnic representation in our research. The Lakembe study that Dr. Elliott mentioned and showed the statistics for is really an exception in this area. As Dr. Hill mentioned, most studies in the ADRD space have single-digit representation from individuals from communities of color. And that's true of the imaging studies, that's true of the all the biomarker studies that are really kind of driving the future of diagnostics. Think about the potential ramifications of establishing thresholds, cut points, determining what's significant and not significant for biomarker positivity in essentially non-Hispanic white samples, and then just assuming that those cut points, thresholds, and the interpretations are going to be meaningful for everyone, when what we know increasingly about ADRD is that this is a very heterogeneous set of disorders, and even within what we try to squarely call Alzheimer's disease pathology, there's great heterogeneity. It was largely the non-Hispanic white researchers that got us into this trouble of being failing so massively on the inclusivity front. So it's going to take, we have to be involved and at the forefront of pushing toward better representation. We can't let this failure fall on the shoulders of our colleagues of color to address. Yes, we have to partner. We have to do this work. One does have to acknowledge, one's own positionality, with respect to race, ethnicity, and then has to really partner with community members and with research teams, build research teams with staff members and co-investigators who represent some of the same racial and ethnic backgrounds that where we're trying to make better inroads. So can white people do it alone? No. Can Black people or Hispanic people do it alone? No. So it's going to take really diverse research teams to tackle these really big challenges. So I thought I'd just, kind of point out the elephant on the screen.
Yeah, and as a follow-up to that, Dr. Lingler, part of your research actually focuses on recruitment innovations to enhance diversity in Alzheimer's disease research. So could you maybe share a little bit more about that and what you've discovered thus far?
I will, and and anytime I say it really isn't me. It is a team. It's a team effort. So just giving some shout outs to those who aren't with me today, but I'm representing my team, but I partner really closely with Dr. Sean Williams from the University of Virginia, Dr. Renee Robinson from Vanderbilt University, and Doctors Judy Cameron and Denji Ren at the University of Pittsburgh. It's very much team effort. So what we've done, this is a massive problem. Trying to increase representation in research. And there are many different angles and strategies that one can take to try to improve. And unlike the kind of science that was described in the overviews of clinical trials, where you can have a placebo control condition, for example, infuse saline instead of the active antibody to make clean comparisons, our area of science is pretty messy. And it can be difficult to try to isolate which factors might be having, the ones that are important if we're seeing success. So our team is really passionate about trying to elevate the rigor in this space and to get more credit to this representation science and recruitment science as not only real science, but one of the actually hardest kinds of science to do because there are so many factors. But our team's approach has focused on just one aspect of this. We've focused on communication and messaging around Alzheimer's research participation opportunities. And our big picture kind of idea is that generally messages about research opportunities flow from, they kind of flow from investigators and scientists who've designed the research in the first place. So as a result, we tend to have these sort of matter of fact, objective lists of risks and benefits of study participation and bullets about what research entails. And that's all really important. But our approach has been to use narrative to, instead of starting with the points that are prioritized by research leaders, to instead talk to patients of color in particular, who've participated in research and elevate their voices. So what we've done is collect stories and weave them into narratives to share and disseminate widely stories of specifically Black and African American research participants with the goal of inspiring other people to do so. So this is called a culture-centric approach. So they lead with what's important about being in this research. They lead with what their experiences have been with respect to the downsides of research participation. Yes, we of course follow ethical standards and include all the information that people should have in making a decision about research, but it's just that starting point is different. So our approach has been that how we communicate about research is really important. And we've shown things like, for example, that after watching a video of a participant sharing her story, 72% of a community-based sample of 500 individuals who are not currently involved with Alzheimer's research say that they would be interested in getting involved. And that's people in midlife and late life, and based on hearing a Black research participant explain why it is that we need people who aren't having any changes in their cognition or thinking to be involved in the research, having her explain why that's important and has been motivating for her. So yeah, we see lots of signals, but one of the things that we're really hoping to do going forward, I mentioned sort of disentangling effects. One of the big lessons coming out of COVID, as health disparities were really magnified and caught the public's attention, And as we saw how, many major threats to public health do have disproportionately negative impacts on the communities that are struggling the most. One of the things that we realize is we have to better compensate people for the opportunity costs of being in research. So if I have to take time off work, or my daughter has to take time off work to get me there, the opportunities lost could cost someone from a more disadvantaged background more so than someone else. It's kind of a luxury to be able to be in clinical research, to have the time, resources, access to get to do it. So one of the things we've done, so we've seen our numbers come up really in a big way in Pittsburgh, but we've said, wait, we also started paying people more. So we have to try to disentangle these effects so that others can learn from them. Yeah.
Thank you, Dr. Langler. Our next question is for Dr. Biber. Why is it so important for a data repository such as the National Alzheimer's Coordinating Center to promote DEI? And what strides has NAC taken to promote DEI?
Hi, thanks so much for that question. So for all the reasons that have already been mentioned by all the speakers here and more, it's really important goal of the NAC and the ADRC program to support DEI. NAC is really here to help support and facilitate the ADRC program in doing that effectively. And we're really trying to do that across all the different areas of work that we do. So I talked about how we serve as like the centralized data repository, but also as this communication and collaboration hub for the Alzheimer's Disease Research Center program. So one of the ways that we're doing that is we're rolling out a new version right now of what we call our uniform data study, which has been going on for about more than 23 years now, in collaboration with those Alzheimer's Disease Research Centers that I mentioned. And it's really, there's updates that are made to that, the forms and the standardized data that's collected across all of those centers every few years, really to be able to keep pace with scientific discoveries, et cetera. And one focus this year in rolling out these new data collection instruments has really been on social determinants of health. And so for the first time, there's going to be mandatory data collection focus on social determinants of health from across the ADRC program. So that data is going to be really, really critical for better understanding how those factors, right, impact Alzheimer's disease, risk factors, disease progression, et cetera. So we're really excited to have that data be a resource that's available for researchers moving forward. We've also been focused on, with those new forms, making sure that they're more inclusive of gender and race. And so that includes, capturing things like multiracial identity, which we know is a very important factor, and also including more inclusive questions on gender and sexual orientation as part of that data collection. We're also working to make this study more accessible to different populations by translating these forms with partners into Spanish and Chinese, so we can ensure that we can access Spanish-speaking and Chinese-speaking populations, which is really important. We've also transitioned to making the forms themselves more accessible through making sure that they're available virtually. So we have those forms that are now with a new electronic data capture system, and that means that those forms and that kind of data collection will be more accessible to folks in rural populations, et cetera. In addition to that, we're establishing new partnerships with minoritized populations. One example of that is we've recently launched an Indigenous Alzheimer's disease-related dementia advisory group, which is led by Dr. Yoe Loon McCluster Davis at University of Wisconsin, and we are partnering with that group to develop best practices for engagement of Indigenous populations across the United States. And are really excited to develop some best practices through that work that we can share with Alzheimer's Disease Research Centers to help support them in really developing sustained and meaningful relationships with Indigenous populations. Another way that we're involved in this type of work is through the big biannual meetings that we put on. We put these on twice a year, where we bring together more than 900 researchers from across the Alzheimer's Disease Research Centers program to really convene around some of the most important topics in Alzheimer's disease and really dementia. And so over the past several meetings, we have really worked to weave in DEI as an important theme as either the theme for the full meeting, which we did back in the fall of 2022, or as an important session within the meeting. And obviously, just talking about things is not going to solve these really critical problems, but we do think that it's really important to highlight work that's happening in that area and to highlight resources that can be used to make sure that these studies are as inclusive as possible and to convene researchers around that work as a stepping stone towards of course, making progress. Lastly, we've had some awards that have been focused on supporting research at the intersection of DEI and Alzheimer's disease. And that is really important. One way that we're really working to support more research in that area, which is under-resourced, and to ensure that we can uncover more important insights into how we can best advance work in that area. So those are some of the examples of how we're doing that, and we're working to build on that further.
Thank you. Our next question is for Ms. Sanchez. How can ordinary citizens contribute to legislation that promotes equity and inclusivity in advancing dementia care? And has this ever been successful in Texas or the United States? Or some examples?
Yeah, thanks. So Dr. Hale mentioned one example that was successful at the federal level, and that was the Equity in Neuroscience and Clinical Trials Act, or ENACT Act for short. And so this legislation was successful. It was introduced in the 117th Congress, and with the help of our advocates, it was supported bipartisanly. So from across both aisles, we had a lot of support in Congress. And the key aspects of the ENACT Act were adopted into the FY23 US budget. And so this is really the ENACT Act really aims to, as Dr. Hill touched on, really diversify our clinical trials, in doing so by trying to increase efforts to increase diversity among clinical trial staff, so that when persons with the disease are looking for clinical trials and meeting with their clinical trial staff, they're working with staff that maybe looks similar to them, that they're trained in cultural competence. Also, the ENACT Act looks to really do some heavy outreach in these underrepresented communities that are of higher prevalence. So really going into the Black African American communities, the Hispanic Latino communities, and trying to really understand the stigma or the distrust, the mistrust of research. And so that's one example at the federal level. I think at the state level in Texas, this is something that we're continuing to really advocate for. But last legislative session, we were successful in increasing the state's investment in Alzheimer's care and support. And so some of the funds that we were able to secure for Alzheimer's disease is aimed at a public awareness campaign for underrepresented communities, to talk about recognizing the signs and symptoms, because that's where a lot of this starts. A lot of the stigma begins with, they notice some signs, but they're attributing it to normal aging. And these signs and symptoms of dementia are not a part of normal aging. But, how do we help these communities understand that, right? So recognizing the signs and symptoms, and then encouraging them to speak to their primary care physician, which is often, the kind of the first in that a lot of individuals have. They're not going to go see a specialist from the get-go. It's their family medicine doctor, their internal medicine, their primary care physician. So part of that is also from that state funding that we got, is working with primary care physicians, is a separate public awareness campaign for primary care physicians, aimed at helping them diagnose, making sure that they're adequately trained in how to diagnose and detect accurately, but then also that we're encouraging them to kind of maybe understand implicit bias, right? Also cultural competency, ensuring that maybe that their staff, that they have bilingual staff, that signage in their practices maybe reflect or are in a language similar to the community in which they're in, so that these communities feel supported and feel seen and heard when they're going in to get that first kind of access to care. And then I think kind of the question about, you know, what can ordinary citizens do? I think it's using your voice, using your experience, using your stories. Really, we pride ourselves in really the power of story. And our advocates they're really the ones that are the driving force between our advocacy efforts and our policy efforts. It's really, you know, calling your member of Congress or connecting with, you know, the Alzheimer's Association, you know, saying you want to become an advocate. You know, we take you to meetings with us, with our members of Congress or legislators, because we can talk to the members of Congress and legislators about facts and figures day in and day out ad nauseum. But at the end of the day, it's the real life experiences that they're going to remember. It's the faces of their constituents that are experiencing this disease that they're going to remember when they're on the floor voting. It's not going to be the number that I, you know, said to them over and over again. So I just, you know, encourage anybody, you know, that has an experience or that wants to really make a difference, you know, to connect with, whether it be us or any other patient advocacy group, to really use that voice to drive change.
Thank you so much for that. And I guess building off of that, going to Ms. Scott at the more organizational level, can you elaborate on how Care Partners has been working to provide equitable access to respite care services, and what lessons have you learned from these efforts?
Yeah, I would say it simply boils down to doing two things to do this work in the community: listen and partner. And so that's really what we've been doing with our work. And the Alzheimer's Association here, our local chapter, has been an amazing partner and is part of the reason why we're spearheading some of this work that we're doing. So, you know, over the past 2 years, Care Partners, along with the Alzheimer's Association and other nonprofit organizations, some of our healthcare partners, have been trying to identify where there are major gaps, who's getting left out, how can we address those needs? And so Care Partners actually recently received funding from the Administration on Community Living to really develop some pilot programs to better improve the support for some very specific populations. And these populations were identified because we listened. So the first population we're working with is the Hispanic and Latinx population, and looking to provide a more concrete and more integrated network of supports. So the Alzheimer's Association has some supports. Some other partners have supports, but it's all been kind of one-off, hodgepodge. And there hasn't been a real clear connector between those supports. And so we're trying to create that. We have now added a caregiver consultant specifically to serve the Hispanic and Latinx population here in Houston. We have also integrated some education programs that have been well received in other communities like ours, you know, very large, diverse communities like Los Angeles. So we're bringing that to the fold. And we're working with the Alzheimer's Association, and we're working with our other partners to also integrate what they're doing into the work that we're doing. We are also piloting some community-specific offshoots of what we call our Second Family program. So this is an in-home companionship program, but run by volunteers. And so volunteers can really assist those with dementia, maybe diagnosed or not, and providing them with transportation to and from the doctor's appointment, transportation to the pharmacy, companionship. If they don't live alone, respite for the family caregiver. And so the offshoots that we're doing, one is for the Hispanic and Latinx community, but then the other one we're doing is for the LGBTQ plus community. And that is part of this project because we were approached by our community partners and they said, look, we're seeing our population aging. They do not have the same networks of care and support. We see a lot of individuals that are isolated. We know that you have this model. Can we figure out how it works best for this population? So that's the second population we're addressing. And then the third is individuals with intellectual and developmental disabilities. And that came, again, because we listened. We were actually approached by an IDD serving population in Greater Houston who said, our population is aging. They're developing dementia, and we don't know how to care for them. Our teams don't know how to respond. They don't know the difference between, you know, the IDD related behavior and the dementia related behavior. And we said, all right, let's try to tackle this together. And when I say together, I truly mean it. We have a network and a partnership of over 8 organizations coming together to tackle these issues because we know these are not our expert areas, right? We need to bring the experts in. And so I think that's one of the lessons learned. And it's something that I've been learning throughout my career, and everyone on this call should remember as you're going into your careers or whatever you're doing, is you cannot do this alone. It is truly about partnership. Everyone brings together a certain piece of the pie. So Melissa, in her advocacy, if she did not do the advocacy work that she did in Texas, we as a long-term care provider wouldn't reap the benefits. And if we weren't having conversations, and if I wasn't sharing with Melissa what I'm seeing on the ground level, she can't bring that above. So I would say, of all the lessons learned, talk to your partners, make sure that your net is wide so that you can better address these issues in your community.
Yeah, I really, really love that. So although I'd love to continue this amazing conversation, I do want to respect our panelists and our attendees' time. So I think I will just ask each of our panelists, including Dr. Hill, to provide any final thoughts regarding the future of addressing healthcare disparities for Alzheimer's and related dementias. And we can go from Dr. Biber to Dr. Linkler to Ms. Sanchez, Ms. Scott, and then end with Dr. Hill, if that works for everyone.
Absolutely. So we need to understand, right, the environmental, the sociocultural, the behavioral, and the biological drivers of health inequities and disparities related to Alzheimer's. And that's what's really needed to make real change in this area in the field. And in order to do that, we need data, right? And we can't just, get that data by snapping our fingers. We really have to build trust and respectfully, meaningfully engage historically minoritized populations in Alzheimer's research. So that's really, really critical, and that's work that NAC is working to support and facilitate for the ADRC program. Thanks.
Yeah, I would just use the last moment to thank the organizers once again for putting this together, and to just really encourage those participating, listening to the webinar today, that if you heard something that you thought was inspiring, something that sparked your curiosity, to please consider reaching out to one of the speakers panel members, or liaisoning through Jillian and Leo to get to folks. You really are the future of this work, and excited to have this opportunity to have interacted with you today.
Yeah, I think it's been an amazing panel, even just for me to participate in. But I think Katie really touched on it, and it's really just the power of our partnership that I think that is really where the future of the work in DEI and dementia really is we in the association cannot do it alone. We need our trusted partners that are trusted in these underrepresented communities. We need, all of our care partners. We need those gain the data. So it really is takes a village, as the cliche goes. But it really is true. And, I invite, all of the attendees today to also continue being a part of that village, and contribute in any way that you can.
I think I already preached, but I guess the last thing I would say is really, truly listen to understand the lived experience. I think Melissa talked a lot about storytelling and how impactful that is. And data is important, and there are people that love data and get connected to data, but then there are people that get connected to the story. So make sure that when you're advocating for this, you have all of these different pieces in your pocket, and then you listen to what someone's lived experience is, because then you're building trust and you're able to move the needle a little bit more.
Yeah, and I'll jump in. I tell you, Leo, what a wonderful conversation today. And, Dr. Sims gave us, a real level set on the treatment. And Dr. Elliott really, assured us, that the government, in this case, the National Institute on Aging, is doing all that it can to utilize taxpayers, dollars, for innovative research. Really just blown away by Dr. Lingler and her work at in Pittsburgh, and just the breadth of evaluating community engagement strategies, at an ADRC. Just really encouraged that there are researchers, NIH-funded researchers that are doing that work, and then of course, Katie Scott, your work in caregiving, always so critical and important. This time, this is the beginning of the treatment era, and it's a critical time, one that we're all excited about, but Dr. Lingler, gave it to us straight. And that it's just, we've not done enough in this space as it relates to inclusion and representation. And to move the needle there, we've got to have a real eye towards health equity, and I'm old enough to remember the process of getting an MLK holiday. I'm kind of telling my age, but at the time, there was a public support, but not much support in DC. And it wasn't until advocates, community people came together using the arts, using all that we could, to show the merit of that kind of a movement, that the needle was reached, and we just celebrated an MLK holiday just weeks ago, right? And so when people say, "Oh, it's never happened before," we'll never get representation in trials, all of the disease outcomes, the clinical trials have little representation. I believe that we can, push forward, because I've seen, this power of community, come together. So at this critical time, one that we're celebrating treatment era, I just remember, a Dr. Martin Luther King quote, graduate of Morehouse, that the time is always right to do what is right, right? The time is always right to do what is right. And so we don't have to be bogged down about what hadn't happened in the past. We can start right now. And I'm just so encouraged about the National Alzheimer's Buddies, really expanding the scope to the kind of volunteer that could help do what's right and join this fight. And looking forward to gaining even more equity advocates as we push forward, and really just celebrate the panel discussion and celebrate the symposium. Thank you.
All right, thank you all so much again for that truly powerful discussion. So we'll begin to wrap up our symposium now. In line with our theme, Advancing Dementia Care, the speakers and panelists featured today showed that amazing work is being done on all fronts to improve the quality of care for every individual living with dementia, regardless of their background, really just giving us hope in this fight against Alzheimer's disease. Each of them is also a testament, as they emphasized in the panel discussion just now, to the importance of public awareness and partnership, ensuring that information about these advances is also made accessible to everyone in our communities. So before we fully conclude, we would like to highlight some of the initiatives that our organization, National Alzheimer's Buddies, is working on to improve the accessibility of our own volunteer work. Over the past several years, our Diversity, Equity, and Inclusion Committee has been spearheading the creation of community-based chapters that aim to serve underrepresented and underserved older adults with dementia. We have currently established community-based chapters in Chicago at Northwestern and St. Louis at Washington University, and are working to bring community-based activities to Fresno, Houston, and Boston currently, and hopefully expanding even further. This year, our Chapter Relations Committee also began an educational initiative to raise Alzheimer's awareness by targeting digital graphics to community centers across the United States. Finally, the Brown Alz Buddies chapter, the Brown University Alz Buddies chapter, in partnership with Brown University Athletics, is actually hosting an Alzheimer's awareness women's ice hockey game on Friday, February 16th at 6 p.m. in Providence. So if you would like to honor a loved one who has been affected by Alzheimer's, a purple ribbon will be hung on the glass at the game on their behalf. The form to submit their name can be found on our website. And for more information about the event or to receive a free ticket to the game, please visit allsbuddies.org/allsgames. And for more information about any of these initiatives that we just discussed, all of that information can also be found on our website.
And with that, we would like to conclude our 4th annual National Alzheimer's Buddies Virtual Symposium. 2024 marks the 13th anniversary of National Alzheimer's Buddies, and we wanted to thank everyone for joining us today. Thank you to all of our speakers and panelists for your thoughtful intellectual contributions, and thank you to the National Alzheimer's Buddies executives and interns for their contributions to making this event a success today. At this point, you should see a survey link in the chat. We would greatly appreciate if you could fill this form out in order for us to receive feedback on today's event. This should not take longer than 1 minute, and by filling out the survey, you will be entered to win a $25 Amazon gift card. Additionally, since National Alzheimer's Buddies is a nonprofit organization, we always welcome donations to help us improve our outreach to those living with dementia across the United States. If you feel so inclined, you can donate to us through our website or using the QR code on the right. Finally, be sure to check out our website, allsbuddies.org, for regular updates on our organization's work and for more information about how to get involved. Thank you again for taking the time out of your Saturday to be part of this event, and I hope that you all have a wonderful weekend. Thank you all.